Hi, this is a podcast about blood transfusion. My name is Sarah Michaels and I'm currently an F2 in Haematology at Darent Valley Hospital in Dartford. So the objectives of this podcast are to clarify the basic science behind blood components, and then we're going to look at the safety aspects of blood transfusion. So the plan of this presentation is that we're going to start by looking at SHOT, and that stands for Serious Hazards of Transfusion. Then we'll do an overview of ABO and Rhesus D blood typing and look at the differences between a group and save and a cross-match. We'll then look at various blood products and then safety aspects in terms of sampling, prescribing, administration, monitoring of the patient and documentation. And then we'll finish with adverse reactions. So the SHOT scheme is a voluntary anonymised reporting scheme, and it collects data on serious adverse events and reactions of transfusion. Reporting is actually done via the MHRA and SABRE, and that stands for Serious Adverse Blood Reactions and Events. So that can be a bit confusing. But basically, it shows that the biggest risk with blood transfusion is when the patient receives an incorrect blood component. The actual risk of transmitted infections is really low. So this is a pie chart, and it shows an overview of SHOT cases between 1996 and 2011, and we can see that the biggest hazard of transfusion between those years was in the transfusion of an incorrect blood component. That was followed by acute transfusion reaction, which we'll look at later, and then also graft versus host disease, and also inappropriate transfusions. So in terms of incorrect blood components transfused, the biggest area for errors to occur in 2011 were in the handling and storage of components. And again, we can see that unnecessary transfusions also come into this part, as well as special requirements not being met. So now we're going to look at ABO grouping. Now, ABO groups are named after the antigens that are present on our own red blood cell surfaces. So we have red blood cells, and they have antigens. And then we have plasma, and plasma produces antibodies. Now, the antibodies that your plasma produces is against antigens that are not present on your own red blood cells. So looking at group O individuals, they therefore have in their plasma antibodies to both group A and group B. And group AB people have neither of these antibodies. And that's what makes Group O people universal donors and Group AB people universal recipients. So looking at that more closely, so let's take Group AB for example. So a person with Group AB has antigens to A and B on the surface of their red blood cell, and they don't have any antibodies in their plasma. And Group O people have no antigens on the cell surface, so they therefore produce anti-A and anti-B. Group A people have A antigens on the blood surface and therefore produce anti-B. And people with Group B blood have B antigens on the surface and produce anti-A. Now, there are loads of other antigens, and that's why a full cross-match actually takes longer in the lab than a group and save. So just a few mils of incompatible cells with the wrong type can trigger a massive immune response, and that can lead to shock and DIC, and people can die from circulatory collapse and severe bleeding or renal failure in minutes or hours. So in a life-threatening situation, Group O blood can be safely given to all groups of people. FFP, platelets and cryoprecipitate are issued on the basis of ABO and Rhesus D group. And unlike red blood cells, they don't have many antigens. Now, the Rhesus D system is something that you'll come across in your obs and gynae placement. And it's the second most important blood grouping system because the Rhesus D antigen is really immunogenic. So red blood cells which carry the Rhesus D antigen are Rhesus D positive, and 85% of the population have these cells. Now, these patients can receive any type of Rhesus blood. Rhesus D negative patients who do not have the Rhesus D antigen on the red blood cells should receive Rhesus D negative blood, because the problem is that they can make the antibody, which is called anti-D, if they're exposed to Rhesus D positive cells through either transfusion or pregnancy. And in case of a pregnant lady, it won't affect her current pregnancy, but the antibodies will be there in a second pregnancy, and these antibodies can attack the fetus's blood and lead to a hemolytic anemia. Now looking at blood availability, we've already said that group O blood, and specifically Rhesus D negative blood, can be used in emergencies before a patient's group is known. And this is known as flying squad or emergency blood, and it's available immediately. Group compatible blood, i.e. a group and save, and that's really just looking at the basics like ABO and Rhesus D, and that tends to be available within about 10 to 15 minutes. But if you need a fully cross-match blood, which is the safest, that tends to take about 30 to 40 minutes to process. So you really need to think about how urgent is this blood transfusion. If you can wait 30 to 40 minutes, you'll get all the antibodies tested and you'll get a fully matched blood, and that's called a full cross-match. If a patient has weird and wonderful antibodies, however, it can take a bit longer and blood will need to be brought in from an outside location. So if time, go for a full cross-match. So in terms of testing, we don't really need to know about this. It's done in a lab, but very briefly, a patient's red blood cells are tested against specific monoclonal antibodies, and also their plasma is tested against specific A and B cells. In terms of Rhesus D grouping, your blood's tested against 2 specific monoclonal reagents. Now, if you've been transfused in the last 3 months or have been pregnant, the sample for cross-match is usually only valid for about 72 hours. And that's due to the risk of developing antibodies to blood antigens. In fact, in my current hospital trust, if you have received 3 units of packed red cells, you can't then request more without doing another sample for group and save or cross-match. In terms of special requirements, we need to think about this particularly on a haematology ward. Now, irradiated blood inactivates the donor T cells. So if you've got an immunocompromised patient, such as someone with an acute leukemia, and they receive red cells that aren't irradiated, the donor T cells in the sample that you're giving to them can actually attack the recipient's tissues and organs, and that leads to graft versus host disease and can cause death. CMV negative components are produced from donations that have been specifically screened for cytomegalovirus, but these tend to be used as standard now. Now, red blood cells have a shelf life of 35 days and they need to be stored at 4 degrees in an authorised blood fridge with an audible alarm system. The transfusion needs to take place within 4 hours of removal from the 4 degrees storage. And unused red cells that have been out of the fridge and haven't been transfused within that time absolutely have to be returned to the HTL, which is the Hospital Transfusion Laboratory. And there needs to be clear documentation confirming the length of time out of refrigeration. These cells will ultimately need to be destroyed. Platelets are actually stored at 20 to 24 degrees on an agitation rack, and they have a shelf life of just 5 days. If they're unused, again, get them returned to the HTL, but they can actually be reissued because they haven't come from a fridge. The infusion for platelets has to be completed within 4 hours, but this tends to happen very commonly over 30 minutes. FFP and cryoprecipitate are stored at minus 30 degrees for up to 2 years. And once a request is received for them, the component is thawed at 37 degrees. Now, the transfusion again needs to happen as soon as possible and within 4 hours, but usually happens within about 30 minutes, or the transfusion goes in over 30 minutes. Now, we need to think about indications for blood transfusions. So for red blood cells, it's anemia. And I know different ethnic groups have different classifications of anemia. But in an acute situation in the hospital, look at whether the haemoglobin level is under 70 or under 80 in cardiovascular disease, and that's normally an indication for transfusion. However, if that person has a chronic anemia, say for example they have sickle cell disease, and they walk around normally with an HB of 75 and can go about their daily business, they probably won't need a transfusion, and that's something you need to think about. And you know, however, if a patient is symptomatic, then they most likely do need the transfusion. And so 1 unit of packed red cells can lead to a 10 gram per litre rise in haemoglobin. Platelets, they are used to replace lost platelets or to increase the amounts. And certainly on a haematology ward, you see patients with very low platelets, and that's a standard, unfortunately. And we don't tend to get too worried about it unless they're actively bleeding. So, we commonly have patients with platelets around about the 25 to 50 mark, and we don't do anything about it. However, if they're about to go for a surgical intervention, we tend to give them platelets beforehand to boost their count so that they don't bleed out on the table. And plasma is given to people with low levels of clotting factors and also some rare blood disorders. So here you need to think about, well, has a patient got a high INR and or active bleeding? So in terms of benefits, we've already touched on these. So with red blood cells, you get relief of symptoms like tiredness and shortness of breath. You can increase the circulating volume quicker than your body will make new cells. And you can also use red blood cells to increase hemoglobin before preemptive blood loss at surgery. Platelets are used for correction of bleeding. And plasma, where you use clotting factors to aid clotting. And FFP has loads of clotting factors, but cryoprecipitate does contain mostly fibrinogen. So you might need to discuss with a senior what type of plasma product you need to give to individual patients. For safe sampling, this is really important. So confirm the patient's identifiers verbally with the patient if they are able to communicate with you. So ask them their name, their date of birth, and their age. And then check these details on their wristband and on the blood request form. If the patient doesn't have a wristband, you can't request a group and save or a cross match for them. That the lab will refuse it. So make sure that the patient's got a wristband. So take the blood sample and then immediately afterwards, i.e. at the patient's bedside, hand write on the tube, unless you are allowed to use stickers, and check that the details on the tube and the patient wristband and on the request form all match before you send them off. Otherwise, again, the lab won't process your request. So for safe prescribing, start by asking yourself the question, does the patient actually need this transfusion? Signed consent isn't necessary, but you do need to discuss with the patient the indications, risks and benefits, and any alternatives where appropriate. And you need to document this discussion in the patient's notes. You do need to find out if they've had a previous transfusion before, and this will highlight if they have any special requirements like irradiated blood. But normally the blood lab will do this for you, or you can call them and ask them. However, bear in mind that some patients might have been transfused in different hospitals, so your current hospital might not actually have that information. So do ask the patient whenever you can. So pre-administration checks, check the prescription form, check the fluid balance chart, and check the transfusion record to make sure that the component that you've prescribed is correct, and if the patient has any of these special requirements. And then also you might need to think about, well, are they in heart failure, or is there a risk of pulmonary edema, and should I actually prescribe a little bit of furosemide with, say, the second or the third unit. Also check that the patient's given consent and ensure that baseline OBS are recorded. So before setting up the transfusion, just have a look at the bag of blood or platelets and just check that you can't see any signs of discoloration or leaking or clots. And uber importantly, check the expiry date and time, although the lab tends to do that for you, but always double check. And then when you're at the patient's bedside and you're about to set up the transfusion, you need to check their identifying details again. So verbally with the patient, if they're able to respond, and on their ID band, and just ensure that all the information, the details are the same as on the label that comes with the blood component. And then compare the lab label of the blood component with the actual bag itself, and just to ensure that the component numbers are exactly the same and it's the correct blood group, and ensure that any requirements are clearly indicated. So where you document, i.e. prescribe the transfusion, is usually on the back of the drug chart with the IV fluids. And most blood components actually have stickers that come with them, and you just peel that off and actually put that on the prescription chart. Put the rate down and get it checked and signed by 2 professionals, and do the start and end time. Now monitoring has to happen pre-transfusion no more than 60 minutes before it's set up, and this is baseline temperature, pulse, blood pressure and respirate. These OBS get monitored about 15 minutes after the start of each unit and on completion of each unit, unless a patient is really unwell and they need more frequent observations. So we've already talked about the recommended infusion times. So about 3 hours for red blood cells. It needs to be within that 4-hour window, and you need to account for the time that it's going to take the pool to collect the blood products and for the nurse to set up the transfusion. So we normally prescribe that at about 3 hours or 3.5 hours. And then FFP, cryoprecipitating platelets, they tend to be prescribed to go in for over 30 minutes. Now we're going to look at reactions. And initially we're going to look at acute transfusion reactions. So these are reactions that take place up to 24 hours after transfusion. So first of all, we'll look at febrile non-hemolytic transfusion reactions. And that can just be where you've got a temperature rise of about 1 to 2 degrees or up to about 38 degrees. And in cases like that, you need to slow the transfusion and offer paracetamol. However, this can be more severe. You might have someone with a fever of over 39 degrees with rigors and chills, myalgia, nausea. You need to stop the transfusion in this case and get senior help. Other reactions include acute intravascular hemolysis, and that's when you've got incompatible infusions, such as giving AB blood to a Group O patient. Septic shock can happen, and that's most likely with platelet transfusions because they're not kept in the fridge. These can actually be life-threatening. Then you've got allergy urticaria, which happens occasionally. Anaphylaxis is rare, but can happen. You get hypotension sometimes. TACO is another acute reaction, and that stands for transfusion-associated circulatory overload. And that's when you get pulmonary edema. And the risks of this are if the patient's over 70, they don't weigh very much, they have heart failure or renal failure or low albumin or pre-existing fluid overload. Signs and symptoms to make you panic are respiratory distress, tachycardia, increased blood pressure, pulmonary edema, and positive fluid balance. TRALI is different to TACO. This is transfusion-related acute lung injury. And that's when you get acute dyspnea with hypoxia, and chest x-ray shows bilateral pulmonary infiltrates during or within 6 hours of infusion. But this actually isn't due to circulatory overload. This isn't something that I have ever seen, but it's something that you certainly do need to be aware of it. So this is just a brief summary of the signs and symptoms of transfusion reactions, and they can be classified according to mild and severe. So mild, you might just have a pyrexia of about 2 degrees above baseline. You can also get urticaria, that's mild, and a rash. But severe, you might have pyrexia and rigors, hypotension, loin pain, anxiety, pain at the infusion site, respiratory distress, dark urine if they've got a hemolysis going on, severe tachycardia, or even signs of DIC. So we've already touched on the management of a mild transfusion reaction, but you generally tend to stop the transfusion and get senior help. If it's just a mild temperature rise, as we've said already, just pause it and then offer them some paracetamol. But if you're at all worried, stop it. Get senior help. Check the compatibility of the component for the patient. Is it the correct component for the patient? Do ABC, reassess as you go along and treat each sign and symptom, and document the adverse events in the patient notes. If it's a severe transfusion reaction, stop it. Get senior help. Check compatibility of the infusion for the patient. Actually take out the administration set. Replace it with a fresh cannula somewhere else. Give IV saline to maintain the blood pressure, and send the set and the cultures to the lab for investigation. Do your ABC and continually reassess. High flow oxygen. The patient may need adrenaline or a diuretic. Check the urine for hemoglobinuria. And again, report the adverse event and reaction as per trust guidelines. So that will eventually go to shot. Hemolytic transfusion reaction is actually a rare type of reaction, and it's seen in patients who've developed red cell antibodies from past transfusions or pregnancies. So they might present with fever and actually a conversely falling hemoglobin, and also look for jaundice and check their urine again for hemoglobinuria. So investigations, urinalysis, HB, Usinase, bilirubin and haptoglobin. You can do a direct antiglobulin test and a repeat antibody screen as well. Unfortunately, there isn't a specific treatment. It's simply that they probably just need further transfusing. And again, report the adverse event. So we've looked at acute complications. Now we're looking at delayed complications. These can happen days to weeks after the transfusion. DHTR stands for delayed hemolytic transfusion reaction. And commonly you can get red cell antibodies from previous transfusions or pregnancy, and it might actually not be detected initially in the lab when you send off your initial request for your group and save. And again, these are patients who might need a further transfusion because they've got hemolysis and they've got falling hemoglobin. Another delayed complication is transfusion-associated graft versus host disease. You can also get post-transfusion purpura as well as iron overload. Infection is another risk. Bacteria is the most common, and I hear that platelets are more at risk of this because they're not stored in a fridge. So the risk for hepatitis B tends to be about 1 in a million, and for HIV 1 in 6 million. The risk for variant CJD is uncertain, but it's very low. So we've been discussing allogenic blood transfusions, so blood components taken from other people, but there are alternatives. So for example, if someone is a Jehovah's Witness and they're undergoing needed surgery, they might be offered an autologous transfusion, and that's where their own blood is recycled. Other alternatives to transfusions, such as in chronic anemia, are iron therapy, and that can be given orally, or if the patient can't tolerate that with the constipation and the taste, that can be given parenterally as well. And you can also, or alternatively, give the patient erythropoietin. And also tranexamic acid is used quite commonly. So this is the MDT slide. It's by no means exhaustive, but we need to consider the whole team when we're talking about blood transfusions, as in any part of medicine. So here we need to think about the porters. They're very kindly going to pick up the blood components for us and bring them to the patient or to the ward. You've got the lab staff who are doing all these tests on the red blood cells looking for antibodies. Blood bank receptionists who might be taking your call at 4 a.m. when you call in a bit of a panic because you've got a patient with a hemoglobin of 4.9. Blood transfusion practitioners tend to be senior nurses with a great deal of experience in blood transfusion, and you can ask them for advice at any time. They tend to be responsible for teaching medical staff about safe and correct prescription and administration of blood components. You've got your ward nurses, and they're probably going to be the ones who may even bleed the patient for you for your initial group and save, certainly setting up the blood transfusion and doing the monitoring of the patient pre, during and after the transfusion. And then of course there are doctors. Bear in mind also you've got a haematology team on call to help at any time if you're at all worried about a patient. So in summary, we've looked at the grouping of blood types, focusing on the antigens and antibodies. We've looked at availability of blood components, their uses and perishability. I haven't discussed pricing here, but I guess we don't really need to know that, but obviously your hospital is going to be, your trust is going to be concerned with that. Safety, safety, safety. Do all of your checks properly and document. Deal with reactions promptly. Get senior advice and help and report to SHOT. And remember MD team working. So you will probably only be involved in a sampling and prescribing of the components, and of course dealing with the adverse reactions, but you do need to have a good working knowledge of the processes involved. So thank you for listening to this podcast about blood transfusions. I hope you've enjoyed it.